Ooh, hi, everyone. Welcome to a new episode of Sarcoma Sisters. I know we haven't been here in a while, since 2021. So welcome 2022. Happy New Year, everyone. Yay.
Happy New Year.
Yay. So Wendy and I thought we would kick off this new year with the two of us discussing a recent paper or publication that came out about a Ewing sarcoma study. The official title is a phase 3 trial adding Vincristine-Topotecan-Cyclophosphamide to the initial treatment of patients with non-metastatic Ewing sarcoma, a Children's Oncology Group report. So we wanted to just discuss it and then hopefully see what you guys think. Give us feedback on this. We kind of wanted to go through, since this is our first time discussing a paper, just to give you a little bit of background on Children's Oncology Group and trials, and then just kind of go through the paper and let us all know what you think. So I'm going to have Wendy kick us off talking just about Children's Oncology Group trials, just kind of in general.
Oh man, I was going to ask you what Children's Oncology. No, I'm just kidding. It's fine.
You're the resident expert now.
But first of all, I don't know if you're going to cut this out of editing, but Sarcoma sister Lisa had a new baby. That's why we took a little break and work.
We don't need to cut that out. Yeah. So, Wendy started, well, gosh, it was the end of 2020, right? At Mayo Clinic. Can't remember when your big move was. Yeah. And then, and then I had a baby in June of 2021, and it took a few months to get back together. And I thought we would get back together sooner, but it took longer than I thought, those babies. So anyway, thanks, Wendy. Yeah, no, I was really excited. I needed to have just as many kids as Wendy. So now we each have two. But this is definitely the last one for me. I don't know about Dr. Allen-Rhoades, but
there's no more Dr. Allen-Rhoades babies. All right, so this paper was recently published. It came out just a little bit ago, maybe like a month ago, I think. And so this is a report of a clinical trial that was run. Yeah, it came out December 20th, actually. This is a report of a trial that was run through the Children's Oncology Group. So I don't know if we talked about clinical trials before. I know we've talked about second opinions.
We did with Dr. Wilkie. We talked about clinical trials.
Oh,
and then a little bit in our second opinions episode, we talked a little bit about it too. But still, it's always more additional information. It's good.
Yeah. So this
recap.
So this trial was run by the Children's Oncology Group, and the Children's Oncology Group is a consortium, a research consortium in North America, New Zealand, and Australia, I believe, are all the people that are included. And so what happened, or why we have research consortiums and why we are part of the Children's Oncology Group, is just so that we can more effectively run clinical trials and learn about childhood cancer. So childhood cancer is rare. All of childhood cancer is rare. And specifically for like Ewing sarcoma, we have about 350 cases across the US every year. And so in order for us to be able to adequately study the disease, we need patients enrolled on the trial, and not one single institution would ever have enough patients in a reasonable amount of time to run an institutional study where we're just studying the patients that we take care of at our own institution. So research consortium are the way that we sort of collaborate together. And it's not unique to children's oncology. Adult groups do this too through alliances and research consortia. So it's done sort of across the cancer research community. But our group is called the Children's Oncology Group, and most children in the United States that are treated for cancer are treated at an institution that is part of the Children's Oncology Group. I would say, I think it's up to like 90 or 95% of children are treated at COG sites. So Children's Oncology Group is also known as COG or COG. So you might hear us flip back and forth. And so what they do is they design trials, and institution that is a part of the Children's Oncology Group is eligible to open that trial. And if a new patient comes into Mayo Clinic, then they can enroll that patient on that trial if they think that it's appropriate. And then the consortium does all of the study conduct, making sure that the trial is run correctly, that it's safe to proceed. They do all the data analysis, and then they report out the results. So that's what we want to talk about, is the reports of this clinical trial. And it is a phase 3 trial, which means that we the investigators or the children's oncology group was looking to see if this new regimen of chemotherapy was better than what we would consider our standard of care. And standard of care means that we take the regimen that has the best outcomes and say, if you're not treated in a trial, we're going to treat you with this because we know that this is what historically gives us the best outcomes when we treat patients as a whole. So we were looking at a new regimen compared to the one that we would consider our previous best regimen. How's that sound?
Yeah, no, that's a great recap. Yeah, thanks, Wendy. So I think that's what we're going to talk about too, because when we talk about Ewing sarcoma, then we could be talking about different patient populations, and depending on the type of cancer or sarcoma it is, then a lot of times it's broken into the patient population, and that includes, it could either be the stage of the cancer, or also if patients have been treated already with chemo and then their cancer returned and then they're treated with a different regimen. So Wendy, did you want to tell us, like, what is the patient population in this paper?
Yeah, so this clinical trial was looking at patients that had newly diagnosed, so never treated Ewing sarcoma, where it was what we call localized, or meaning it had not spread to any other parts of the body. So if it started in the leg, it stayed in the leg. If it started in the arm, it stayed in the arm, etc. So patients that had never received any chemotherapy, surgery, or radiation were eligible if they had localized disease. And yeah, that's the patient population.
Yeah, exactly.
I'm like looking down my cheat sheet, and I have like a whole bunch more information.
Good. Yeah, we want to make sure we're telling you guys everything as it is, even though we both know this trial because we had patients enrolled on it. But yeah, so it's localized, exactly what Wendy said, meaning it's not patients who had a tumor in more than one spot, like if they had what we would call metastasis to the lungs or something else, and then they must have never been treated with chemotherapy. And then, like Wendy said, we want to build on what we know from our previous clinical trial, because of course we're trying to get better results, meaning better in our number of patients who survive and who don't have the cancer that the Ewing sarcoma that comes back. So that was one thing we were going to mention, is what is this being compared to, meaning what was the standard of care that we're looking at to try to do better than?
Yes, the other thing I did not mention was you had to be 50 years or younger. So we didn't have any of our older, like very older patients in this trial. And I think usually when we go up into that older age range, it's very few people that are above really like 25 or 30. Mm-hmm. So, but we did exclude it because once you get beyond 50, chemotherapy looks very different.
Yeah.
Okay.
Definitely.
All right, so I guess the other thing that we should mention before we start looking at the results is that this was a randomized trial. So randomization means that patients are enrolled in the trial, and then they're randomly assigned to either one regimen, which would be the standard regimen, or the experimental regimen, which is the one that we're looking at to see if it's better than the other one. And the physician that is treating the patient that has enrolled them on the trial does not assign the randomization. It's done by a computer system at the Children's Oncology Group, and it's randomized. So that's that. The caveat to that is in this study, because we know, like you said, Lisa, different populations tend to do a little bit better, a little bit worse based on where the tumor is or how old they are. We will often put them into buckets first. So for this one, they put them into buckets of, if you were younger than 18 years old or older than 18 years old, they would put them into that bucket and then randomize, just so that each arm didn't have a bunch of older patients that would then not do as well, because older patients don't do as well. And so we want to make sure that the criteria of those things are evenly balanced between the two arms, so that we can adequately interpret the results. Yeah,
and that's called stratification, right?
Yes.
Yeah, so so everybody is equally, you have the same number of people who equally get one treatment, which is a standard, versus the other treatment. But then also is equal is the number of patients, for example, for this study, who were over 18, So if you're over 18, it was also an even number, or we try to get even number as close to it, that were into the standard of care arm or the other arm. So that way we understand the results better, because if you have everyone over 18 who just happens because by chance to get into one of the arms, then it's still not going to help you out, because you can't really figure out if they if there's a difference, or if it's just because they all got put into the one arm just by chance of when they were enrolled. Yeah.
Yep.
Cool.
Yep.
And we know we are no statisticians, so we hope we're breaking this down well. So let us know, give us your feedback. But and then did we want to talk about well, we want to talk about the regimens and also what we are looking at, what we call objectives in the study. So before we talk about well, when we talk about standard of care, it's really based on what we call the endpoints of the study, or what are we looking at. So of course, what we always want to look at is that patients who receive the new therapy, are they doing better or not? Because if not, we know our new therapy isn't any better. So different clinical trials, depending on their phase and where they're at and what we're looking at, have different what we call endpoints. And so so the ones that we use typically in sarcoma studies through Children's Oncology Group is event-free survival and overall survival. And Wendy, I don't know if you want me to keep talking, or if you want to talk about the difference between the two.
All right, so I think the easiest one to define, that's easiest to understand, is the overall survival. So for trials, we often look at the 3-year overall survival or the 5-year overall survival. And that's looking at patients that 3 years from their enrollment or 5 years from their enrollment, are they alive or not? So that's overall survival. But then the other thing that's really important is looking at, and obviously going back to overall survival, the patients who are not alive, are not included in that number. So we can say, 70% of the patients are alive at 5 years after the trial has ended. So we're counting the people that have passed away from various things. And so the other thing that we look at is event-free survival, which is a little more nuanced, but might be a little bit more meaningful, is that we're looking at the patients at 3 years and 5 years, and we're saying, did they have an event? So what would an event be? An event would be, did they relapse? So they could still be alive, but they could be living with relapse disease. And that is telling us that that therapy didn't work in the way that we wanted it to, because the disease came back, or the tumor came back. Another event could be, did they develop some complication from the therapy? And the main one that we look at is secondary malignancy. So did they develop a second cancer that we think is attributable to the therapy that we already gave them? So we tend to look at event-free survival more closely, because we want to make sure that our patients aren't alive but living with relapse disease, because that becomes a very difficult clinical situation, and we would prefer that our patients don't relapse after therapy.
What we compare that to see if it's better than something is the standard of care, which means what are patients getting that are not on the trial, and then what are we going to use as our, since this trial had 2 arms, what is the arm that has a standard of care? So Wendy, I'll have you explain what that standard of care is, and then we can talk about what the experimental arm was and how it was different.
Yeah. So at the time when this trial was started in 2010, the best data that we had was using a regimen that had 5 medications in it: Vincristine, doxorubicin, cyclophosphamide. So that was 1 cycle. And then we alternated that with ifosfamide and etoposide. So those cycles roughly alternated every 2 weeks. So we would give one of the 3 drugs, and then 2 weeks later, we would give one of the 2 drugs, and we just sort of repeat that. There's some nuances in there, which I won't get into. And when we use that combination in a fashion that was given every 2 weeks, our outcomes at that time in 2010 were a 5-year overall survival rate of 83%. So 83% of our patients were still alive. And the 5-year event-free survival at that time was 73%. So that means that there was still there was 10% of people that were alive, but had had an event of some type, whether it be a secondary malignancy or a relapse, but they were still alive. So that was the best outcomes that we had at the time in 2010. And so that's what we were comparing that to. And that regimen had 14 cycles of those alternating chemotherapy cycles.
Great. And then, so in this current trial, the AEWS 1031, what did that have in it as a arm that we were trying to do better with?
Yeah, so we knew from some earlier phase studies, so like a phase 2 study, that there was medication called topotecan, which was a different class of drugs than what is in the 5-drug regimen that I just explained. We knew that topotecan worked in patients who had relapse disease, where their disease would come back, or disease that was no longer responding to therapy, which we call refractory disease. And so this study was designed to see if we could add in topotecan in a cycle and improve the overall survival. And the way that we added that topotecan in was we did it in combination with 2 of the other drugs that they were getting, the vincristine and the cyclophosphamide. So instead of just the VDC, the vincristine-Topotecan-Cyclo, alternating with the ifosfatopicide, in between, we were adding in cycles of vincristine, topotecan, and cyclophosphamide. So in order to do that, because we were adding in more drugs, we didn't want to necessarily decrease the amount of drugs that they were already getting, because we didn't want to cut back on anything, because we didn't feel like our event-free survival was high enough to cut back. We went from 14 cycles to 17 cycles to make sure that the arms were even. So we increased the total length a little bit more and then added in that new drug.
Yeah, thanks. And I know that's a lot without a visualization. I was going to say I can show a picture from the paper that just lays out the drugs and the doses for those of you who are watching. Let's see. Oh, except that it doesn't want to do it right now anyway. But in the meantime, I guess what I can try to bring that up, but then, so Wendy, and then did we already talk about, well, I guess we talked about the primary objectives, meaning the primary things that we're looking at were overall and event-free survival. And we talked about the regimen, but then that just talking about the regimen, and like you said, how we wanted to do 17 cycles instead of 14, that just reminded me of what we call secondary objectives, or other things that are also important that we look at. Because with a new regimen, you of course want to look at survival, but also, as I think that all patients and families will appreciate, is that we want to look at quality of life and toxicity and those things. So some of those secondary objectives were toxicity, meaning is the new regimen more toxic, or does it have more side effects than the other one? And then also, we want to look at, we want to break out the groups a little bit different. And that's what, Wendy, I can't remember now if we already talked about stratification or not.
Well, we partially talked about it. So
yeah, but that's what some of the other secondary objectives to look at just these groups of patients. Looking at if, for example, with Ewing sarcoma, if the size of your tumor makes a difference if you do better or not with either of those regimens, or if we talked about if the age of the patient, if you're more than 18 or if you're less than 18, and oh, I'm missing one. There's the age, the size.
site.
Oh yeah, the site of the tumor. And then I think, did they do something different with local control also? Or was that just something I don't think it was a stratification. I think they just looked at that also. Yeah, and then sometimes, yeah, we have things we stratify, meaning the buckets that Wendy was talking about. And then we also have things that we also look at to see at the end if it seemed to make a difference or not. Because some patients, with those of you who are familiar with Ewing sarcoma will know that some patients, depending on where the tumor is located, may get radiation instead of surgery, or in some cases, radiation and surgery. So they were also looked at to see if that made a difference or not.
Yes. So going back to the stratification, so the reason that they were stratified by age, we already talked about, because patients that are older than 18 tend to have not as good of event-free or overall survival. And then patients with extra osseous, so meaning soft tissue tumors, not in the bone, they tend to do a little bit better historically. And then patients that have pelvic bone disease, so in your hips and your kind of sacral area and things like that, down in the tailbone, those sorts of pelvic tumors often have not as good of outcomes as compared to if it's, in your arm or your leg, which is probably multifactorial. Those are hard to get out with surgery. They're hard to treat with radiation, but we know that those have historically been a group that we struggle a little bit with. And so again, we wanted to make sure that those were not all sort of lumped in one of the regimens and none in the other, because it would skew the results. And so that's why those were stratified.
Yeah. Thanks, Wendy. That's a very important point too, because when we look at these trials, no trial is going to be perfect, but we want to try to get the most accurate information we can to know that these results are the best that we could possibly get based on how we design it. And so we're making the best decisions for future patients. One question I want to ask that I don't forget to ask at the end is, Wendy, if this trial started in 2010, why are we talking about it in 2022? Why does it take so long?
Yeah.
And when did this trial end?
Yeah, so the trial, so it's funny, this is the first trial I ever enrolled a Ewing sarcoma patient on as a fellow. I was a fellow in 2010. And I remember it very clearly. So it's kind of a historical fact for me. But yes, it started accruing in 2010 and it stopped accrual in 2016. So it took in January of 2016, so pretty early. So it took about 5 years to enroll patients. And the reason that it took that long is just because the number of patients that we see is not that high. So in all, there were 642 patients enrolled. And so I said earlier that there's about 350, is that right? Ewing sarcoma patients. Per year in the US. Now, obviously, we have a couple of other sites in Canada, Australia, New Zealand, et cetera. But not all of those patients are going to have localized disease. About 70% of those are going to have localized disease. And sometimes, for whatever reasons, patients might not want to enroll on the trial. The patient's physician might not think it's appropriate for them, or other reasons. And so it just takes a long time to get that many patients enrolled because our numbers are so small. And then, because our outcomes are 3 or 5 year event-free survival, we have to wait for pretty much that last patient so if it finishes enrolling in 2016, we have to wait another 5 years so that we can analyze all the data once it's mature. So we don't want to analyze it at 1 year, because the patients that were enrolled in the later part of the study, their data wouldn't count towards the outcome. And the study is designed that we need that many patients to make sure that we can see the effect that we're looking for, so we can say if it worked or not. And so it takes a long time to accrue for rare diseases. And then because we're looking at 5 year event-free survival, it takes a long time for the data to mature. Yeah. And the reason that we pick 5 years, I think, is also something we should maybe talk about. Yeah. So for different diseases, we may pick 3 or 5 years. It's very different than adult trials where they might be looking in terms of months. For pediatrics, we know that the average person who's cured from a childhood cancer will live about another 71 years. So it's important that we have a lot of length or longevity on our outcomes, but that's different than adult cancer. And the reason that we pick 5 years for this trial for localized Ewing sarcoma is because we know that at 5 years, most people after, how do I say this? That we know that if you finish your therapy, your highest chance of relapse is between 0 and 5 years. Most relapses will happen in the first 3 years, and then maybe 10 to 15% will happen in years 4 and 5. And so that's why we're always looking at 5 years in childhood cancer studies. If there is a disease that's a little more aggressive and we know that they relapse a little bit faster, i.e. high-risk rhabdomyosarcoma, then sometimes we'll look at the 2 or 3 year event-free survival. But for a disease that has a relatively okay outcome, it's not great, but it's better than some of our other ones at 73%, we know that we should probably wait that 5 years for that data to mature.
Yeah, thanks, Wendy. And even if you're thinking, well, 350, that still shouldn't take that long. It's that that not every patient who's diagnosed with Ewing sarcoma has localized disease. Some patients will have metastatic disease, so they wouldn't be eligible for the trial. And then not every patient and their family feels comfortable enrolling on a clinical trial, or may have it open where they're at. Even though most of these studies are open throughout the US and every state, it still takes a while to open. And so all those are reasons that it takes a long time. But we still know that, and we still even though it takes a long time, it's really important to get this information. That's the only way we're going to improve. So we got to just take that hit and just go for it and get some results. So thanks, Wendy, for explaining all that. So now
the other thing, maybe, sorry to cut you off. The other thing is that some patients are not eligible just based on how well their kidneys work, how well their heart is working. Pregnant people are generally not allowed to enroll on oncology clinical trials. If there's, brain involvement, they were allowed on this trial. And so there's just reasons why people wouldn't be eligible also.
Yeah. And, sometimes to people that might seem like we would say maybe the word cherry picking, that you're only picking the best patients, but we want to make sure that these drugs work. And so the only way to do that is to have a specific population of patients where everybody's kind of even across the baseline, meaning nobody has kidney failure to begin with or issues with their kidneys from the tumor, and nobody has issues with their heart to begin with, because those patients will be treated too. But in order, again, to understand the results the best way that we possibly can, we need to have kind of a baseline for everybody. And one of the cool things kind of in oncology now is a lot of people are looking at what they say real world data, where there's certain systems that can kind of look at all these patients that aren't even on clinical trials and see kind of how they do too, to see if we want to change our standard of care. I think that we'll be using more in the future too. But for now, this is the best way we can get kind of an even population of patients to really know what our results mean. All right, so now I think that we'll go on to talk about the results of this paper and what we learned from this clinical trial. And we can kind of break that down too. But Wendy, do you want to take a stab at just talking about the primary outcomes, or that event-free survival and overall survival, based on the two different arms of study?
Are you making me do this because I took all these notes?
Yes, because you have all the notes in front of you. You can't see my little notes over here that aren't as big. Ooh, I got notes down there too.
Oh yeah, there we go. Okay, so this trial, like I said, enrolled 642 patients. The standard arm, which is those 5 drugs that I talked about, was called Regimen A, and there was 309 patients enrolled on Regimen A, and Regimen B, which added the new drug, the topotecan, enrolled 320 patients. And so the primary aim was looking at, does adding that topotecan improve outcomes for patients with localized Ewing sarcoma? So when we look at the event-free survival, the 5-year event-free survival, it was 78%. And as a reminder, the previous trial, the 5-year event-free survival was 73%. And when we look at the 5-year overall survival, it was 87%. And previously, the trial before that, the 5-year overall survival was 83%. And so there was a small improvement in event-free survival and overall survival compared to the previous trial, which we should probably talk about how we compare new trials to old trials. But when we look at the regimens, so when we look at Regimen A compared to Regimen B, so when we look at the standard of care, I should probably start with that, huh?
Yeah, that's
just erase that part.
We could just start with this trial and then comparing it to the old trial. Okay.
So okay, let me try it again.
And then I'll ask you again. Yeah.
Sorry, Lisa.
No, it's good. This is our first time doing it. It's hard. Okay. All right, Wendy. So I think we'll switch to now just talking about the results of the trial, and we can kind of break it down. But I think first of all, we'll start with what we talked about, those primary objectives and endpoints, looking at the event-free survival and overall survival, comparing those two arms of the standard of care arm, which was the 5-drug, the Vincristine-Topotecan-Cyclophosphamide versus ifosfamide and ifosfamide etoposide, versus the new arm, which had the topotecan added to it.
Yep. So the trial enrolled a total of 642 patients. It was pretty evenly divided between the standard arm, which had the 5 drugs, which was called Regimen A. So Regimen A had 309 patients randomized to it. And regimen B, which has 6 drugs because we added in that topotecan, had 320 patients randomized to it. So when we look at the standard arm, the regimen A, the event-free survival was, the 5-year event-free survival was 78%. And when we looked at regimen B, which added that topotecan in, the 5-year event-free survival was 79%. So there was no difference in the 5-year event-free survival between the 2 regimens on this study. When we look at the overall survival, so how many people are alive at 5 years, regimen A, the standard arm, was 86%. And when we look at the new regimen that had the 6 drugs with the topotecan in it, it was 88%. So that was not statistically significant. A 1 to really 3 to 4% difference in survival or outcomes is not statistically significant. So the overall aim of this study was looking at, does adding Vincristine-Topotecan-Cyclophosphamide to the previous regimen, which was the alternating cycles, does that improve outcomes for patients with localized Ewing sarcoma? And the results of this study showed that it did not improve outcomes comparing adding in that topotecan to what we were already doing with the Vincristine-Doxorubicin-Cyclo alternating with the ifosfatoposide.
And I just wanted to ask you real quick, just to explain what statistically significant means, just what,
yeah,
because we know the numbers are just a little bit different, 86 versus 88.
Yeah, so there's always a little bit of what is like statistical noise. So it's the reason that we do averages when we're, trying to figure out like what an average sale volume is or things like that, that there's little differences that can happen. But and I am not a statistician, even though I've taken many statistical courses, I still can't do it. There are people that are hired and do the statistics on these trials who are angels on earth, but they're looking at is the difference seen more than what could just be happening with chance or noise? And the answer was no for this study.
Yeah, I remember like in all my stats classes, they're talking about when you flip a coin, if it's heads or tails, and then like it'll be 50% of the time will be heads and 50% of the time will be tails, but sometimes it'll be like a little bit higher, 60-40, but that's not, is it really something that we should pay attention to? Is it a big enough change that it's actually what we call statistically significant? So thanks for explaining that, Wendy. So it wasn't statistically significant, meaning there was no difference between the 2 arms. So then what about compared to how we did on the last study? Did we do any better in the survival or not of patients in the event-free survival?
Yeah, so I think there's a couple of important points about that study, and one of them is this, and the other is sort of looking at those subgroups in the population. But it's difficult to compare. There's no way to statistically compare a trial that was run 5 years ago to this one because they're not exactly the same and the arms weren't the same. But we do always look back and say, historically, are we doing better than we did before? And so when we look at the 5-year event-free survival from the previous trial, which did 14 cycles of ifosfamide etoposide alternating with the Vincristine-Doxorubicin-Cyclophosphamide, the 5-year event-free survival on that study was 73%. And on this current study that we're talking about, it was 78%, so about 5% better. When we look at the 5-year overall survival, on the previous study, it was 83%, and on this one, it was 87%. So again, 5% better, 4% better. So, there was a trend towards things improving, but it's not comparing apples to apples. It's just looking at historically. And so I think there's a lot of discussion that's happening in the Ewing sarcoma community and among treating physicians of what does this mean? Does this mean we, should switch everyone over to this regimen? And we can talk about some of the caveats to that. But nonetheless, it certainly wasn't any worse. And so it gives us some options when we're talking with our patients about what we should put them on for a regimen. And then I think I'll pause there for a second, but we can kind of dive into some of the other things that I thought were important in this study that are a little bit more nuanced. So I don't know if you want to talk about that, Lisa, or if you want me to keep going.
Well, the only other thing about the, just to reiterate, I guess, what you said about comparing it to past studies, it is hard because what you said, they're not the same population. We talked about that, actually, I'm not sure if we mention it now because we did a little editing. In the previous study prior to this one, there was 14 cycles of chemo, where there was 17 in this current study. And I think you did explain that, yes, because you were talking about the amount of alkylators, the amount of chemotherapy that we wanted to compare, make sure it was evenly comparable between the two studies. So so you might say, oh, well, then the reason why this was 5% or 4% better was because there was more therapy, but we can't really say that because it's different patients, meaning there was different patients previous to 2010 who were on the other study that are in this study. And it's at a different time when we have different supportive care, meaning other things that we do to help patients who are receiving therapy. And there's always different factors that we don't even know the unknown unknowns that we can't even account for. And then what you're saying, Wendy, and just to make sure that I understand, is that in Ewing sarcoma, then the doctors are trying to decide is because the outcomes were comparable, meaning between the two arms with the topotecan added or without, we already said they weren't statistically significant. They both had around the same event-free and overall survival, that they're trying to decide if they should give them the topotecan or not, which would be the better choice option for the patient.
Right. So that's one question. Should we give people a topotecan, or because our standard regimen was a little bit different than the standard regimen in the previous trial because of that sort of length of cycles, should we give 17 cycles of the standard regimen, or should we do the 14 cycles? Should we give them longer therapy or shorter therapy? So there's options sort of built in there because things are relatively equal. And so that's a very one-to-one discussion with somebody's physician about how they're tolerating the therapy, what's important to them, where their primary tumor is, how old they are, are you going to do surgery? Are you going to do radiation? Are you going to do both? I think all of those things come into play. And I don't think there's going to be a blanket there is not a blanket recommendation from anyone really, and it's not really the children's oncology group's position to provide recommendations for therapy. They are just reporting the results and then leaving this up to the individual physicians. So some things that are sort of nuanced that I think about with my patients that are not buried, but are deeper into this trial is those patients that were 18 years old, their event-free survival was 75%. And that is better than what we've seen anywhere, because our best for these older patients were 63%. So why did that happen? That seems like a pretty meaningful increase. And I would probably think about giving this regimen compared to some of the older regimens just based on that, because I think that's important. That's an important shift for those patients. And again, is it just the chemotherapy, or is it because we have better surgeries, we have proton therapy now? There's a lot of differences that I just won't be able to tell, but it's sort of hard to look away from that data. So that's one point. And then the other point is that the patients that had pelvic disease or pelvic bony tumors also had a 5-year event-free survival of 75% compared to bony tumors that were not in the pelvis, which was 78%. And that is an improvement because we haven't ever had comparable outcomes between pelvic and non-pelvic bony sites. And so I think I would probably talk to a family that came in with a pelvic Ewing sarcoma about that and try to give them this little bit longer regimen of therapy to try to eke out a little bit of better outcome for them.
Yeah, that sounds like very important information. And like you said, it's one trial, but we had a lot of patients on here. And so, that bit of a difference can make, when you're looking at these populations where the overall and event-free survival isn't as high, these small tweaks might be able to make a difference.
Yep. And then think the last important thing that's deep into this is in the supplementary information. So anytime we treat somebody for cancer, there's a risk that we could trigger a different cancer. So the medications that we give, the radiation that we give is damaging to the DNA of the cells, which can cause changes in that DNA, which then can go on and develop a secondary cancer or a secondary malignancy. On this trial, our rate of secondary malignancy was a little bit higher than what we had seen previously. So in the previous study, we had seen a secondary malignancy rate of about 2.8%. So 2.8% of the patients on the previous trial developed a secondary cancer. On this trial, it was 4.3%. So it was higher than what we've really ever seen. And it was, when this happens, we look at, did more people get radiation versus not, because radiation can induce other sarcomas like osteosarcoma, et cetera. But on this trial, most of them were leukemia, which sort of points to the fact that it's probably the chemotherapy that is causing this. So etoposide and cyclophosphamide are known to cause secondary leukemias. So even though historically these are the best outcomes we've seen, there is some caveats to it. And I think we have to be careful and again, have an individual conversation with the family about the risk benefit of giving this regimen, knowing that there's a slightly increased chance, small, but real increased chance that they could develop a secondary malignancy after they've completed therapy.
Yeah, I think that's really important. And just like you said, it's just for everything, it's not just a black and white answer. Just like anything in life, there's always important things to consider. And that's why, that your physician is the expert on you and your care. And that's why, just what you're saying, Wendy, that these are conversations that patients and families want to have with their physician to look at their case in particular and figure out what is the best way to go right now or the best regimen.
Yep. Yeah, so I think, overall, this is a very well-designed study. It was a very well-run clinical trial. I think the data is solid. Of course, we would have loved to see that, Regimen A had a 95% survival, wouldn't that have been great? But it's also, as a researcher and as somebody who works with clinical trials, it's also nice to see that we didn't do something that made the outcomes worse, because then you look back and you're like, man, we treated people for 5 years with this and it actually didn't help but made things worse, which is a possibility as we run trials. There are safety mechanisms built in, or interim analysis, to make sure that that's not happening. But that's sort of like the overall worst thing that we could have happen during a clinical trial, is that it's either too toxic and we're hurting people, or it's not enough therapy and they're relapsing way faster and way more often than we anticipated them. But there are safety steps built into trials to mitigate that, but it's always a possibility. So I think I'm happy with these results. The secondary malignancy makes us be cautious, but I think there is populations where this makes a lot of sense for them. But I have a lot of teenagers that might not be too excited about a different length of therapy, but it's just an individual conversation.
Yeah. And then what did they gain from this, because we already talked about what we learned about, but then is there a phase 3 now in Ewing sarcoma where we're looking at a new question?
So there is one in development. It is not up and running yet. We don't have a local or a metastatic one up and running. But they're working on that. They're trying to incorporate some newer medications in, and maybe looking at maintenance in Ewing sarcoma.
So and I don't know if this is proprietary information. That's why I was just thinking, in the new phase 3, do we have any idea then, would they use the standard regimen, meaning the vincristine-Topotecan-Cyclophosphamide and ifosfamide etoposide regimen, or would they use the regimen with the topotecan in it for the standard arm, meaning the arm that we would compare against?
I don't know if it's proprietary, and I'm not on that trial committee. I'm on a different one, but I believe they're not incorporating the topotecan. So, I think that's a good question too, is like if somebody came to me, would I give them the Regimen A standard that was used in this trial? Would I give them the standard that was used in the previous trial, or would I give them Regimen B? Those are sort of the options. For me personally, I would not use the topotecan up front, because if God forbid they do relapse, we know that it is a good relapse regimen, but it's not as good if I've already used it, because then that tumor has already seen it. So because the two arms are equal, I would choose the one and save that topotecan for later if I needed it. And I think that is also the reason I don't believe it's going to be incorporated into the next upfront trial.
Yeah. No, that all definitely is makes sense. And I think, you know, we could probably stop here. I know we've talked about so many different things with this paper. Hopefully we covered it well. We let us know if if people have questions on this, and if you liked it, because we can definitely review more publications. And I think, you know, this just makes me think that in the future, because of what the other thing I was thinking about, well, you know, we don't have another trial right now, phase 3, where we're trying to answer one of these big questions for event-free and overall survival. So another thing we might do this year is just go over these individual sarcomas and kind of what's out there right now that they're looking at for future trials, which we can also get experts on to talk about that as well.
Yeah, for sure. And we'll probably, this is an open access article, so it's not behind a wall. You can get to it, so we can link it in the
show
episode
notes.
comments.
Yeah, definitely. Yeah, we'll definitely do that.
Yeah, it should be open access because it's funded by the NCI.
Awesome. Well, thanks, Wendy, for me letting me put you on the spot to answer most of the questions with your notes. And
now I'm sweating.
No, you did great. And then we're excited. Thank you, everybody, for listening. We have some interviews coming up in the next few months, and we're really excited about to do them and to have you all learn along with us. All right. Thanks, everyone. Bye.
Bye.